So if I change the slides here, oh, you advance manually.
Yeah.
Okay.
Just let me know when we're ready. Welcome to the HRM Chapter presentation on current research in early psychosis. My name is Donna Mettot. I'm the chair of the HRM Chapter. For those on the webcast, you can type in your questions and Todd, our technician, will read them out just as we can type in any time, and we'll answer as we go. I'd like to introduce Dr. Phil Tibbo, our guest speaker this evening. In 2008, Dr. Tibbo was named the first Paul Janssen Chair in Psychotic Disorders and moved to Dalhousie University here in Halifax. In this position, Dr. Tibbo is leading an internationally recognized program of research into the causes and treatments for psychotic disorders. He is a professor in the Department of Psychiatry with a cross-appointment in psychology at Dalhousie University and an adjunct professor in the Department of Psychiatry at the University of Alberta. He is also director of the Nova Scotia Early Psychosis Program and co-director of the Nova Scotia Psychosis Research Unit. Dr. Tibbo will be presenting an overview of the 5 key findings of the Early Psychosis Knowledge Sharing Initiative. Please welcome Dr. Tibbo. And my apologies for our late start. We'll try not to have it happen again.
Just be careful about that.
Yes. Don't knock that off.
You don't want other apologies going on.
My leg.
Yeah, exactly.
Okay, thanks everybody, and thanks for joining on the WebEx as well. Because of the WebEx, that's why I'm sitting in a chair with the laptop in front of me. So I'm used to standing and walking around when I'm talking. So if I start getting a little bit edgy, you know why. I'm feeling constrained here with this. So as Donna mentioned, we're just going to be presenting tonight really what this initiative was that we were doing last year. And this is this knowledge sharing initiative. And we don't have a whole lot. I don't have a whole lot of slides with respect to this. So I'm hoping, feel free to ask questions as we go through. And Todd, I'm not sure if people type in questions. Feel free to interrupt me as well. Do that. I think for a night like this, it's easy to have that sort of informality there, which would be great. Sorry, I'm going to work with your computer here, Phil. So. And so what was this? This was a knowledge sharing initiative. Actually, this was something that myself and David Whitehorn, actually, and I'm sure many of you know as well, we were talking about certain things, and we saw this opportunity or a call for grants from the Nova Scotia Health Research Foundation. And as usual, I'm always pushing people to put grants in for various things. I said, come on, David, let's put something in for this. Because this was a really great opportunity, because the whole idea about knowledge sharing is that dissemination of some of the research findings. Right? So those of us who are involved in research and we do it, what happens, right, after we do the research, after it's published? We're not necessarily in that process, and some of us, to be honest, some of the researchers don't necessarily have the skills to be able to take that research and then make it something that's either educational or getting that knowledge out there, right? So this was an initiative that the foundation had set up to help support. And I said to David, well, let's put something in. And David actually took the lead on actually getting something together and putting it in. And then the next thing is that we actually got this grant from the foundation. Both David and I always smile at that point thinking, oh, great, we've got the grant, now we've got to do this. But this was a really great opportunity. It was a great learning opportunity for us. And we spent the last year, we kind of wrapped things up from this phase of it in early summer. And to explain really what it was, we wanted to have this knowledge sharing initiative. So it's disseminating some of the research, distilling it down, and discussing some of this research. And we wanted to do that in collaboration with the Psychosis Network in the province. So we wanted this to be a provincial initiative. And there's a couple elements to that. Of course, there's a whole lot of research in psychosis, and so where do you start? And we didn't want to have it too broad, so we actually had a really good discussion. We met as as a key group, and we came up with 5 key areas. And those are the 5 key areas I'll just mention tonight. And that's where we looked at all the literature, we reviewed it all, and we brought it down to a couple of basically key messages more than anything else, right? There is a lot of other research out there. We have applied for this grant again. They've actually changed the process this year, so we'll see if we're successful again. We're hoping we are, so that we can continue this as well. So we focused on 5 key areas. There's different elements to this. We did create a website. We have online webinars. Actually, if you go to the Early Psychosis Program website, the Nova Scotia Early Psychosis Program website, if you just Google that, the website will come up, and within there you'll see a tab that says Key Findings. And you'll see a lot of the information basically is there, okay? And that's, I'm going to blank on the website. It's earlypsychosis.net.
Just Google early psychosis Halifax, it'll come.
I just put in NSEPP and it comes up automatically. So, so within that we have different webinars that we've been doing, some online articles, information along those lines. The other part of this, and we're actually between that interactive part within the website, there's been 300 people or so that have signed on and to get the information. So that's been really quite nice. The other element of this was we actually went out, and part of what the funding actually allowed us to do was to go to 4 different regions within the province, and giving this information more in a workshop type of format. And so what we did, we didn't want to be there, we didn't want to lecture, right? We wanted it to be a very, very interactive kind of component. So we talked about the 5, how those workshops went. We talked about the 5 key messages that we were giving. We do one, and then we had everybody sort of break off into their groups and discuss those key findings. But what does it mean to you? What information? What did you take from that? And then we brought it back into a larger format. The nice thing about this is that within those workshops, we really aim to have stakeholders from a variety of groups, right? So we aim for 8 basically key stakeholders at each of those sites. So that includes not only clinicians, family members, people with lived experiences, but as well different levels of administration and government as well. Okay, and I think we're fairly successful in getting that pretty much within every site. The 4 sites that we touched were Truro, Cape Breton, the Annapolis Valley, and Halifax. Now, we only went to 4. We would have done more, but we only went to 4 because that's all that we had funding for. So that's why we're hoping to get more funding so that we can go back and we can expand on this a bit more, because it was great. We had, I think we within those face-to-face conferences, we had, they were full day, well, 3/4 day conferences. I think in total we had about 120 people in total that we touched. So it was really great. It was really great that way. So as I mentioned there, I mean, the goal there is to, basically make these key findings accessible. The network played a key role in it. We did have funding from the foundation. We actually received some other funding, a small bit of funding from the Department of Health and Wellness as well. It wasn't necessarily specific to this, but it came at a very opportune point, and we applied it to this as well, which was great because we needed it. And just mentioning the steering group there as well, myself and Sabina Abadi, Donna here in the room, Stephen Eyre, Laura Burke, and Dr. David Whitehorn as well. So, just to go on, and so I'll give you a couple of slides, just maybe just a bit of background as well. So this is specific about early psychosis, or early phase psychosis, all right? And this has become a whole field, really, of work and clinical work and research as well. And this whole field of early psychosis has developed over the last 2 decades or so, about 25 years or so. What's really interesting with this field is quite kind of unique, is that right from the onset, there's always been a research element tied in to the early psychosis component, to the clinical component as well, which, and they've worked quite synergistically as well, right? So really what that's allowed is really some informed care, at that particular level, but a lot of, really interesting thing back and forth, trying to figure out what's the best service delivery model, what's the best treatment methods, and all along those levels, as well as more the kind of the basic sciences, trying to find out biological underpinnings of psychosis at those early stages as well. So they really fed off each other. So this is one area we have in psychiatry where service delivery and research just has been going hand to hand together. And you see leaps and bounds of where this has led within where we are today in delivery of services. Because of the recognition of this, there's international associations, the IEPA, that's International Early Psychosis Association, and the very other national associations as well. Now in Canada, I'm a part of a consortium that was started in 2012, and we're slowly sort of ramping up as well. It's the Canadian Consortium for Early Intervention in Psychosis. And so that's development of a national, more of a body as well in Canada. And actually we're quite excited about that and what that could produce for us. Here locally, the Nova Scotia Early Psychosis program, depends on who you talk to, either began in 1996 or 1994. So it was one of the first 3 programs actually in Canada. So it's one of the longest running ones, which is great. It's had very kind of humble beginnings and has morphed into different things over the years. And I came in 2008, and I say and from my perspective, it's a very well, it's a very well resourced program. Could we use more resources depending on what standards you look at? Yes, but I think it's functioning really well as to what the intent and the mandate is. The other great thing about this province as well is that we have provincial standards with respect to early psychosis. And they were developed in 2004. We have gone through a process of updating those and have rewritten those. They haven't gone through the final approval process yet through Department of Health and Wellness. Hopefully soon. We've been sitting on those for a couple of years.
Yeah, I remember working on those a while
well,
back.
then there was an election in between there,
Yeah,
so things happened. So we're actually, there's not, at the time, in 2004, there weren't very many other provinces that had provincial standards for early psychosis. And still in Canada today, there's not that many provinces that have provincial standards. They're slowly kind of developing them. New Brunswick actually, while they don't call them standards, last year they developed, or 2 years ago now, they developed guidelines, more or less. So that helped with some of the service delivery, and that actually then helped with the government to allocate resources for New Brunswick to initiate and start some of these early psychosis programs. So Nova Scotia is actually doing really quite well within this area, within this field. This slide here, I don't think we really need to talk to it a bit. We put this up sometimes because we were talking about psychosis, right? And I just want to, people, psychosis and schizophrenia, what's the difference? There's always that discussion. For the purpose of this, initiative that we have, we are talking primarily about psychosis, and this is where psychosis is that primary symptom. Okay, so if it was a mood disorder with psychotic symptoms, that really didn't fall within this. But if it was a primary psychotic illness, that was the research that we looked at. Okay. So these are the key findings that we thought, okay, this is the information that we want to get out there, right? The areas that we looked at all the research, and interestingly, how we can summarize a whole body of research and bring it down to just a couple of points, basically. We didn't want to have anything that was too, I guess in some ways too new, because if something that was just published in the last 6 months, obviously there has to be some replication of some of the data. Right, so this is very, very solid data and solid work that we looked at. So the first one, thinking about I'm going to go through each one of these, and I have a couple of slides basically on each one of these. So thinking of psychosis as presenting in stages is important, right? Then is the optimal stage-specific treatment results in better outcomes. Treatment delays impact negatively on outcomes, and actually can occur within our healthcare system as well. Family education and engagement are an essential component of optimal treatment. Hopefully no one will argue with me on that point here. And that mental involving psychosis is not necessarily a progressive brain disease. So those were the 5 messages that we put out there and that we discussed within our webinars and within our workshops. So I'm going to go through each one of those in just a little bit more detail. And again, feel free to ask any questions. So the first one, thinking of psychosis as presenting in stages is important. But let me ask, okay, now I'm going to ask you guys, all right? In what way do you think that if we think of psychosis in stages, how can that be important? You guys on the webcast are off easy here on this one.
Well, if it's stages, then there's something different about different periods of the illness, so then that would mean we should be doing perhaps something different or something specific to that stage.
Yeah. Well, let me put it out there. Okay, some other illness, other medical illness.
Yeah. Oh.
Think of some other medical illnesses as well. Have they ever presented to you, or you have that knowledge base about those illnesses being in stages? Ring a bell?
Yeah.
Well, I mean, we don't want to, obviously a big negative one there, but yeah, it's no, sorry, I wasn't being judgmental there on that, but it's a model, right? And that you think of it as in stages, right? And I think that's an important part, and we should be thinking about this within mental health, not only within psychosis, but I think in mental health as well, because you don't just wake up one day and then have full-blown mental illness the next day, right? There's stages to it. Even after you've developed an illness, there are still other stages to the illness, right? And I think we've been a bit, from my perspective, I think we've been a bit naive to think that we have this treatment algorithms that we follow, or, treatment things that we offer, and we think that it should be, applicable to everybody with the illness. It doesn't matter what age they are or what stage they're on, right? And we're assuming that if we give that treatment to this person here and this person here, that the outcomes would be the same, right? And I think we have to move away from that. We have to look at more that stage-specific treatment, which is the second point. But the first point, even before getting to that, is that we have to think of mental health and mental illness and psychosis specifically as staging, as stages. There are some obvious stages, I think, that we have. And this is some of the bullet points with respect to that. Is that obviously psychosis develops over time. Staging is commonly used in other medical conditions, which you mentioned, true enough. And the important part of that as well is very similar to cancer. Some of the things at the earlier stages, how you would treat it, is different than if you had more advanced illness. So that treatment in the earlier stages tends to be less invasive, right, than in later stages. Make sense? So if you're there earlier enough, you don't have to go in with the big guns, right? There are more subtle things that you could do where you can optimize outcomes. Right? Overall concept about earlier treatment is generally more effective, and that tends to be the case. And basically the last bullet point is that we have to get this information out, and that information needed by clients, families, and communities differs according to stages. Right? So we have an early psychosis program. Some of the information, some of our drive and how we package things would be different than somebody who's had the illness for 20 or 30 years, for example. It's not, sometimes it's not necessarily completely different information, but sometimes it's that packaging of that information. And sometimes it is completely different information too, because the needs of somebody who's 18 to 22 are going to be different than the needs of somebody who's in their 30s and 40s, right? So, and that also comes down to not only the needs, but then the treatment, right? So if we're there earlier in the illness, for example, if I go straight to medications, oftentimes the medications we use within the early psychosis phase tends to be at what we call monotherapy, usually one medication and at low doses. Right? And if you compare that to some of the lists that we see, if somebody's been out in the community for quite some time, it's different. It is different. Right? So it's important to be able to think about that, because you can optimize outcomes if you're there at that earlier phase and stage-specific treatment. And I put this up here, what are the stages? There's different ways of doing this. Now, actually, we didn't present on this because it hasn't really been replicated enough, and that, much like cancer, we can the staging of 1A, 2A, 2B, and that, there is some suggestions with respect to how we can do that within psychosis. We decided not to kind of go in that route. And I think people may have seen this kind of stage-specific treatment way of thinking about it as well. Right? And again, this is more or less that progression. Right? You get that onset of psychosis, you get first treatment, and recovery, stabilization phase, and that residual and stable phase as well. Right? So you have that prodromal phase, you have first episode psychosis, that kind of phase, and then you move on from there, right? So we talk about a pre-morbid phase, which basically is, before any recognition of any type of illness, right? That's pre-morbid. Prodromal phase, there's a lot of work that's been going into that, how do we define a prodrome, right? So that's before the frank psychotic symptoms are present. I always, when I'm doing teaching on this and talking to community, say, if anybody has frank psychotic symptoms, delusional hallucinations, anybody can make that diagnosis. Where we need to put our efforts is before that, right? What kind of signs and symptoms exist before that phase? And that's kind of the prodromal or high risk phase, right?
And that phase, is it not, it can be very subtle, some of the signs, and I think.
Exactly, yeah.
Yeah, maybe, and sometimes we think, oh, well, it's a teenage thing, or it's a phase they're going through, and it's really hard to determine that there really is something wrong.
Yeah. Oh, I'm not saying it's easy.
Yeah,
and it's not. I mean, that's where we have to look at perhaps multiple ways that we can answer that question, right? Exactly. A lot of the prodromal risk things are very subtle, non-specific things that are very common to teenage years, right? That, there may be some elements of depression, some decline in functioning in school. And I think, though, really where a lot of that, though, boils down to is the change, right? And it may be a change that's separate from their usual peer circles, right? Or from, quote, the norm that we'd expect of adolescence. Now, where a lot of the work is going into is okay, yeah, there's that aspect, and there's people looking at other sort of biological things that we can tack onto this to make it a little bit more sensitive. So is this something we should be worried about or not? Right? I've always talked, when I talked about across the province and elsewhere as well, and talking to different gatekeepers, I always mention it's that index of suspicion, right? I'm not saying that you don't know if anything's right or wrong, but if you're thinking about it, why not get it checked out to see if it is something to be worried about or not? And I make that analogy to, primary, secondary, tertiary prevention and skin cancer all the time, right? So we know enough knowledge out there to stay out of the sun, right? Primary prevention, wear sunscreen. But we also have the knowledge out there that if we get that funny looking mole, right, we should get it checked out because it may or may not be anything, right? But if it is something, you're there early. Right? You don't wait. You're there early and you get it worked out. We should be thinking about that for mental health as well.
So that's really an education for family physicians for this as well, because this gets missed.
Yep, exactly. I agree.
And not only the physicians, but the families and the teachers.
Well,
Everybody.
I think school needs to start in junior high.
Yeah.
But it's true to have the general public for families to be educated.
How much more is being done for family doctors now compared to a few years ago or whatever? Is there a concerted effort that, like a refresher for doctors to take like a module on mental illness?
There's nothing that's mandatory right
yeah.
now. Now, all the family physicians, all physicians have to get their credits,
Yeah.
to continue to practice. I know we get asked fairly regularly to talk at the DAL refresher course, which is a course for GPs in the region, actually not the Atlantic region. And we are presenting this month as well at that refresher course, just on this topic about identification, early identification. That's what the GPs want. They just want those pearls. Okay, what do I do? How do I, and when I speak to them, because I've spoken to those groups as well, is, look, again, if you have that suspicion, just give us a call. We'll figure it out from there, right? If it's something to worry about. And sometimes we'll go back and say, because it's very gray at that point, so I don't know. I don't know if it's something to, but let's just follow over time. Touch base with me in, X amount of time, depending on what the acuity is and what the changes are. So we're saying you don't necessarily have to jump in with a treatment all right away if you don't really know, but at least if that person's sort of just watching and in the system, then we can catch something if it does start. But any of the gatekeepers need those information. That's the school system, guidance counselors, all the way through, right? Families, general public, and family physicians as well. So but that's a very important part to think of this whole idea about phasing it, because Because it allows us to really kind of focus at different parts of the illness as well, right? Without, excluding all the other parts, but it means it allows us to really look at those and say, okay, what's good for this phase of the illness? What's good for this phase of the illness? Right? So it's a way of thinking, a shift. Right? So there's a lot of research into that. So that's why we just want to present that as a way of thinking, right? And that's how we should be doing that, because that leads into the second one. Of course, that optimal stage-specific treatment does result in better outcomes. Right? A lot of research has gone into this, and as I mentioned here, that clinical staging can provide that useful framework for understanding the illness, identifying targets for intervention, and improving illness outcomes in persons with psychotic disorders. And when we look at the two stages, well, for that, obviously we're looking at improved outcomes. That's our primary goal in all different levels, right? Functional as well as symptoms and along those wells. Where there's been a lot of research within this phase-specific treatment is in the actual first episode psychosis stage, but as well as the at-risk stage too, okay? And there's that clinical at-risk, high risk, as well as a genetic high risk, but there's a clinical at-risk stage that's been defined. And there's actually a fair bit of work that's gone into that.
What do you mean by clinical at-risk stage?
Yeah, it's interesting because they call it clinical, that separates it from a genetic risk. Genetic risk is, for example, if you have a parent or two parents with schizophrenia, right? Or multiply affected family members. That's a genetic risk. That doesn't mean you have any symptoms, but you're just at a genetic risk, right? That clinical high risk, oftentimes how they define it, they use different terms in literature. They call it ultra high risk, clinical high risk. And there's different criteria for that. Basically, it's like attenuated type symptoms. So it's not frank psychotic symptoms, but attenuated symptoms, right? So mildly psychotic symptoms. It may not make the diagnosis for delusion or hallucinations, but close, right? As well as functional compromise, right? So there's, something they may not be functioning as well at school as what they should be. So they're not, again, not frankly psychotic, but just, they're just earlier than, just a little bit on the edge, a little bit earlier than that, right? So that's what we call that at-risk stage, right? So when we look at stage-specific treatments, then in that first episode stage, we have shown, what we've been able to show with the early psychosis programs, right? We look at outcomes of these particular programs, we can have significant effects on symptom levels, right? Remission rates, relapse rates, mentioned some other points there, compliance, quality of life, burden and cost, and suicidality as well, right? And that would be compared to what we call treatment as usual, right? So if you have a group of people who had got illness, right, became ill, went into a first episode psychosis program versus what we call treatment as usual, kind of in the community, right? It's that first episode program, that's showing the benefits over treatment as usual, right? So, we're able to kind of really focus what we're doing within that time frame. The whole cost issue is kind of interesting, because from my perspective, sometimes in the administrative role, it's a very costly program to run. But yeah, we do have a lot of personnel there because these are our outcomes. But look at our outcomes. Don't look at our costs. Look at our outcomes, what we're doing. But what we've also been shown, we haven't done the work ourselves, but other centers that have looked at this, is that if you compare all the costs within the and looking at outcomes, if you look at 8-10 years down the road, right, our costs, somebody who's gone through the program, even just for 5 years, and then graduated, and then we're checking them on 5 years' time, still significantly lower, about 1/3 the cost. Because where we're saving on costs from that administration level is inpatient stays, which is the most significant type of cost we can have in the system. Right? So stage-specific treatment, first episode, yes, and in at-risk stages as well. So at that at-risk stage, what they're trying to look at is preventing or delaying that progression to a full psychosis. So that's where the research has been focusing. Because of this work, then we have had those standards for first episode treatment that have been worked on over the years in different jurisdictions. The whole idea about reducing the duration of untreated psychosis, we're looking at antipsychotic medication, Within the standards, there's a medication component, there's psychosocial, psychoeducational supports, both the patient and family. So it's kind of a really true wraparound service for this individual. Different types of psychotherapy and support for that person. But it's intensive, right? It's intensive as wraparound for that person. There tends to be high remission rates within the first episode programs, greater than 80%. We haven't quite got there with risks with our relapse rates though as well. So we have high remission rates, but they can still tend to relapse as well. So there's work going on that, and we're doing some work on that as well too. And as I mentioned there, which I alluded to before, is that this comprehensive stage-specific treatment gives better results than the generic treatment as usual. Right? The issue that we raise, this is always a sensitive one to bring up, is that what a lot of the research has shown is that when somebody, all the gains that you made within those 3 to 5 years in the first episode program, the transfer to community care, they tend to lose those gains, right? In various ways, in symptom functions and various ways. And there's always something, there's very sad research that has shown that, right? People think really what you first thought is, well, they're not getting, that's the quality of care that they may be getting, or the expertise within the community. It's not necessarily that, it's not a critique in that. But I think it's more sort of that they don't get the same wraparound service. Perhaps the same intensity is not there within that community care component. So what we're looking at, we're in our region, we're going through a process now, we're looking at, how we're delivering services for psychosis in the whole region. And so that's something that we're examining as well. I'm concerned about that one, Doc.
I actually think, the LAPS program.
LAPS, yes, for the, yeah.
I think it should be available for patients in the hospital, something similar, because for my own child, he found that, and he'd been in the hospital a year before he took it. And it's still, he found it huge and thought, I remember at the time, the first day, he said, everybody should have this education, because he learned things right away.
Yeah.
And even if you were relapsing back in the hospital, you could use that information again.
Oh yeah.
To reaffirm.
Yeah. So that the LAPS program is the, for those on the WebEx, is learning about psychosis. It's more of the formal psychoeducation of what we have for patients within the early psychosis program, and it's I can't remember, 7-week or 8-week. Program that we offer. But you're right, that's the type of information that still should be continued. I think there should be updates. Revisited updates. And it should be up there in the community as well.
Yeah.
Right? And the focus may be different, right? But there's a, that focus at the beginning is a lot about the early psychosis, that early phase and what that could mean to you and where you are in your life. But some of those whole elements about relapse prevention and finding a relapse signature and all that, that's something that should be continuously revisited as well. Now, what we do in our clinic too is that we know what's given during those labs, seminars and workshops, and so we bring that in clinically as well. So like if I have somebody one-to-one with me, and I know they've been to lapse, we'll talk about relapse signature. We'll use that kind of language and we'll review that as well. But that formal process, something still that can be done out in the community. I agree. But again, phase specific. It should be offered in the community, but more specific to what their needs are at that point in time. Good. All right. So we know that the treatment for sepsis works. I did mention about remission rates are high, relapse rates though are high. I just want to mention this because this is coming out. This is a paper that I wrote coming out this month actually in the Canadian Journal of Psychiatry, and it's a perspective piece actually. And really, this is a new sort of format within the Canadian Journal. So they just want to, it's almost like an opinions piece. Think of it that way, as a perspectives piece. It's a new category. And a group of us wrote on this relapse risk assessment in early phase psychosis and the search for a reliable and valid tool. And so this is some more of the work. So this is an opinion piece, but we're also following that up with some actual research that's happening and being supported actually in part by the Schizophrenia Society of Canada Foundation as well. Looking at how can we better identify relapse indicators for psychosis, right? For clinicians, as well as they're a tool that even family members could be using as well. Right? which we think would be useful. Now I put that underneath, that's within this, that quote is actually from the perspective piece, because this is where a lot of the research, this is a very large meta-analysis that went on most recently, and they're looking at risk factors for relapse and specific to early psychosis. But these are the 4 out of the like 20, 25 risk factors that existed that were looked at for psychosis. These are the ones that turned up the meta-analysis the most robust. So that includes medication non-adherence and persistent substance use. Right? So that makes sense. I think if you're not taking medication and you're still smoking pot, well, the chances of you guys going to relapse it's going to be there, right? But the other interesting, I put it here, is also caregivers' criticism came up, right? It's not the expressed emotion. People who have been in the psychosis field for a while, there's that whole idea about high expressed emotion in families could be an indicator for relapse or an outcome predictor as well. And we realize it's actually, that's not that, right? But when we look at all the studies, it's the idea of a caregiver's criticism that actually can be an indicator for relapse. And that brings up the whole kind of discussion, well, what is caregiver's criticism, along those lines. And I think in some ways it could be along the lines of, if they're not have the education and you're dealing and working with negative symptoms, what are you saying to your loved one as well, right? Look, you're just lazy, you gotta get up, you gotta do these things, right? That could be criticism. And and actually what they're finding is that could lead to relapse.
Yeah. Oh, I strongly agree with that. And, I think it's critical that caregivers do have that family education.
Right, exactly.
And support, so we know what to say, what not to say, what to do, what not to do, or at least what we should be doing,
right?
Not doing, right?
So that's why I put that in there. That this just, so this is a very excellent sort of meta-analysis. So a meta-analysis where they look at a number of different studies and distill that information down into one particular study. So that's the risk of relapse 4 times. Like I said, medication non-adherence, we have 4 times the risk of relapse compared to somebody who's adherent to the medication. Right? So you see how still the role of the family though, because that caregiver's criticism, 2.3 times the risk, so still double the risk, right? So you have twice the risk of relapse if that's happening within the family and we're not addressing it. So yeah, okay, so that was that early psychosis phase. This is at the at-risk phase that we talked about, right? So we mentioned that there have been criteria that have been introduced for following this at-risk phase. It's that combination of genetic, that attenuated symptoms, that functional decline, which we already talked about. The studies have sort of waffled a little bit over the time period. So we have a range of about 10 to 35% of people who meet the criteria for that high risk who have then moved on to a first episode psychosis, right? So the criteria that are used, what they're saying here, are somewhat valid and reliable for predicting this particular population. Now, I don't know if anybody, Dr. Jean Addington, who's based out of Calgary, came and did a ground rounds last month here. And I know Jean from Alberta and the work that we do, but she's mainly been working in this at-risk stage. It's actually interesting, we don't have a slide here on this, but really what she's showing and what they're showing, and they have, this is the Naples study, and it's kind of more worldwide number of different sites. I think they have about 800 individuals or so that are at this at-risk stage, and we're following them over time. And yeah, it may be a low percentage, that 10 to 20% who may then develop a full-blown psychotic episode. That doesn't mean that the other group, the other 80% or so, are completely healthy. And what they're showing is that other group, they may have these attenuated, all the stuff kind of going on, but they actually may have depression symptoms, they may have anxiety symptoms, so the risk of developing some mental health concerns is high, right? So they may not be going on and develop full-blown psychosis, but there may be something else there that should be addressed, right? So there's still so at-risk, I think, is appropriate. It's not necessarily saying at-risk for psychosis, but they're an at-risk stage. We defined it based on psychosis. But they're still, mental health is at risk. But interesting, we whole talk about stage-specific treatment though, again. So how do you treat these individuals? And these are, usually people 15, 16 years old too, right? Figure along those lines. Oftentimes, antipsychotic medications are not used. Medications aren't used in this group, and it's more psychotherapy. In other words, a CBT approach is oftentimes the best approach to use. And a lot of the research has shown that you just need, the CBT behavioral therapy, the cognitive behavioral therapy is a kind of a treatment of choice. As long as that supportive therapy and the family therapy and the education too. What you see underlined there and bold well is the whole fatty acids and omega-3 piece. There's a lot of good research that has gone into this. And so, just leave out medications. If you actually then go in and give some supplements, for example, the omega-3, that actually has prevented some people from transitioning into a full-blown psychosis, right? So we're talking about, these are, and the amino acids and glycine, I won't go into detail, but they're all about neuroprotection, right? Protection of the neurons in your brain and along those ways, and helping to develop, because the adolescent brain is still maturing and developing like you wouldn't believe, right? You're stuck with your brain at around 30, but before that, in the adolescent period, there's so much that's happening. And if we can have somebody at risk, if we can help try and augment that, well, then it makes sense. It makes sense biologically, and it makes sense in many other ways as well. So when we talk about stage-specific treatment, you don't go in there with a battery of 3 or 4 antipsychotic medications and put them on clozapine right away. There's other ways of getting at that, right? Because that's all they, if this is what they need. But we wouldn't know that unless we thought about this as a stage-specific illness.
What about fatty acids, through later stages of the illness? Is there any effect to?
Actually, they've looked at that and they've shown that it didn't have any effect.
It doesn't have any effect.
Yeah. Which still points towards the biology, right? I mean, again, that brain development maturation in the adolescent period, that's where it would have an effect. If you're in your 30s and 40s, the research has shown that it doesn't have that same effect. You don't have the same outcomes with it. Now, when somebody comes to me and says, or a family member, should I be taking this? And if they're outside of this age group and risk factor, I just, there's no harm, right? So yeah, why not? Let's see, right? We're doing a study, say, with niacin and niaspan, because that may potentially be helpful as well, or as an adjunctive type of treatment. Now, we're not saying it's just all in what we call nutraceuticals or supplements, because at a certain stage, yes, if you need the antipsychotics, but if you have these other elements too that are adding on to it, yeah, there may be benefit. There's no harm in it, right?
What's B12?
Well, B12, again, it can affect neurons. So, that is something, oftentimes, even as our baseline measure, somebody comes into us, and they could be full-blown psychosis, we'll still check B12 levels, because if those tend to be low. Because if you're low in B12, not only can produce sort of psychiatric symptoms, because it can also mimic some of the negative symptoms as well, like the low energy and passivity and things along those lines.
If B12 comes in okay when you have your blood work done,
Yep.
Does that mean that you don't need it?
Well,
Or would the supplements be beneficial?
when you get the lab work for B12, there's actually a range, right, of what they consider normal. That's true with most things like lab work, right? If somebody's still at that lower end of what, even though they're coming back, the lab, it's coming back as normal, and if that lower end, I would still actually add in some supplement of some B12, right? If that at that higher end of what's in that normal range, it doesn't really do any good.
Okay.
Yeah, and these things aren't cheap either, right? So we have to always balance that. Because you get B12.
You're not talking B12 supplements from the pharmacy, or from a drugstore or something, then like a high release.
Yeah, because you get those. Yeah, because you go to that whole section of the pharmacy, you get everything there.
Yeah.
Right. Sometimes you wonder what's in those bottles, but
yeah.
But it's there. I take supplements. I'll take once in a while. I figure I'm not eating right, so I should just why not? So that's just about that at-risk stage. And the last bullet point there is actually even with all this, the results are promising and suggesting that this conversion rates can be reduced, right, by doing this sort of somewhat non-invasive type of therapy or interventions. So the second one, treatment delays impact negatively on outcome and can occur within the healthcare system. Do you guys agree with that or not? It feels like this is a quiz.
Oh, yes.
Yeah?
True.
Oh, yeah.
Okay. From the word that you often hear, I'm sure you guys have heard this already, the terminology we talk about often is about duration of untreated psychosis. Okay? So this isn't necessarily treatment delay, that duration of untreated psychosis is that time period when a diagnosis could be made, right? And when effective treatment begins, right? So when somebody's actively psychotic, but they're not getting treatment for it, right? And a whole host of factors can play a role in that. But as you see there, I mean, a lot of the studies have shown that duration of untreated psychosis, there's a huge range for that, right? It can, you know, a lot of studies, if you pool them all together, you'll see but 1 year, right? And these are actually, think about it, these are people who are psychotic and not getting the treatment, right? The median's about 6 months. We did a recent study here, and actually ours is much less than that, and that's probably because we have that, you know, we've had an identified early psychosis program that people can know that exists and can refer to. Because they've often shown if you have an existing program like that in itself, just because you have a program, it can reduce the duration of untreated psychosis, right? Why we are looking at the whole duration of untreated psychosis is because if you have that long DUP, it affects outcomes. It affects outcomes on many different levels, you know, on remission rates, relapse rates, symptom severity, functional outcome measures, right? Even some of the neuroimaging findings that we have as well.
So psychosis then would include the typical symptoms that we think of, hearing voices,
Yes.
hallucinations, and so on. And that, in our experience, could go on for years before the family is aware of it.
Right.
So that is, if people that under those conditions, that is our experience, are included, that would tend to increase that average.
Right. Yes. Yeah.
So that 1 year seems incredibly short based on our experience. So.
Yeah. Well, like I say, now that's an average of the 1 year, because you look at
Yeah.
the different studies, you'll see a range, right? You definitely will see that range that exists.
Okay.
But the drive really is to reduce that.
Yeah.
Right? And that leads into a whole bunch of questions. Well, how do we do that?
Mm-hmm.
Right?
Particularly if there's lack of insight. Even
Yes.
You
Yes.
know, that's.
So, I mean, there's different scenarios that you can come up with that. You can get, that lack of insight, that person not wishing does not help, seeking doesn't want to get any help, but everybody around them is aware as well, right? Versus a situation where somebody could be, and we use the term quietly psychotic, you just don't know, right? But they are. And they're still able to function to some degree, so they're not really coming high on the radar, but okay, they're not performing the way you would think that they would. And just the delusions, hallucinations are just not as prominent enough where they're talking about them or the behavior is really dictated by them, right? So that's kind of, we call it kind of quietly psychotic, you know, terminology. We know, you know, our goal is to really try and reduce this DUP. I'm sorry, I completely forgot what my next slide is. Oh, yeah, all right. Can we reduce DUP and improve outcomes? And I will bring the attention to this. This was actually a great work that was done in Norway as a country, okay? They identified DUP as a target that they wanted to reduce, right? So they looked at various catchment areas, I guess very similar to our counties within our province as well, right? And in a few of these particular catchment areas, they had very, very intensive public and professional education sessions and case finding. So tons of billboards, tons of radios, tons of TV, you know, as you can just picture, they just flooded the public with this information, right? And about case finding as well. So in other words, you know, if there's somebody that you question, they were quick to bring them in, right? And they compared that then to some of their catchment areas within the country that didn't have that, right? So as I mentioned in the second bullet point, so the outcomes in these catchment areas were compared with outcomes in other areas that did not try to reduce the DUP. Treatment, though, in all those areas was the same. So if somebody actually came in, everybody got the same treatment. So the only thing different within the different areas was this intensive campaign. Okay. With that, I mean, first of all, what they're able to show is that with that intensive public and professional education, case finding, they were able to reduce that duration of untreated psychosis. Okay, this was a very costly thing to do, and we put up the other bullet point. Other researchers have found this difficult to accomplish. At the same time, some of these other groups that have tried this haven't had that same buy-in of a country, of a region, saying, okay, well, we have identified this and we have to work on this. Okay, but you can appreciate how costly that can be with the cost, with the advertisements, right? Alone than anything else. But what they were able to show that with that wash of information, they could affect the duration of untreated psychosis. People were being identified.
It would be interesting if they studied after the campaign, if that still held, that if people were still aware and, kind of passing it on.
The lingering, they're starting to look at it. They're at the phase actually where they can go back and start looking at some of those. I know that they're looking at their data and where it is now. So, yeah.
You used the analogy earlier of skin cancer, where we know now if we see something that we bring it to the doctor's attention and address it early. And I mean, when I was a kid, you didn't worry about the sun, quite the opposite. You tried to get out of it, bathe in it as much as you could, which is very different now. And that, my point is that was through education. There was a lot of concerted effort to educate people as to the harm that is. But I think today, generally, people are there. We don't always, follow the right guidance when the rare days when the sun's out. But most people know that now in North America and most countries, I think. I mean, it can be done. Yeah. Absolutely.
It would be nice to have
that was a generation.
Yeah.
Right? So we may have to take that generation.
Yeah.
But do we have the information that was out there about skin cancer? Are we out there the same in mental health?
No.
Is that the information about optimizing mental health and what you need to, is that out there the same as to what the campaigns were, if put it that way, with respect to cancer, skin cancer? Sorry, Donna.
No, I was just saying that's what we really do need, a public campaign, particularly for early warning signs. Right? I really like the new ad they have out on the brain and smoking marijuana.
Okay.
I think that's that's very well done, and it's not one of those scary reefer movies that we had to live through.
But that campaign's been criticized as well.
Oh, really?
And I had somewhat of a role because I met with the federal minister of health, it was asked to come and speak to her all about cannabis, another area of research that I do, about the cannabis. And it was all about, you can't go in, it has to be something that's specific for the youth, right? That whole campaign in the past about this is your brain on drugs, the egg in the frying pan, failed. It failed, right?
It's like smokers.
It's a smoke, because you talk to a teenager, it's like, look, you're just fear mongering. They'll say, I know what you're trying to do, and it doesn't work, right? So I mean, I like that campaign. I wish it was a little bit better, to be honest.
Okay.
So, but it is good.
Yeah.
Not better than what it was.
But we do need something like that. Something like that, and just the early warning signs, and that treatment, optimal treatment. The earlier, the better. So,
it's like years ago when they had breast cancer,
self-examination.
Yeah, and it was like on every bus. It was on every magazine. Right. Every girl open had something in it, and it was everywhere. But I think women still know now, and this was probably
30 years ago.
Yeah.
So it's got to be kept up over time, though, too, right? And I think it's great. I mean, we should be doing more of this, but it has to be maintained.
I think it's getting better generally, though, about mental illness and all of that, with the Bell Canada and.
But not schizophrenia.
No.
They're still terrified of the term, that nobody wants to use
but you know what,
the word.
If you're packaging it, not necessarily specific to psychosis as well, but just about risk factors for things to look out for mental health issues or mental health problems, for long-term potential mental health problems. I mean, it's an easier package that you can put together that way.
But the words always come out of, it always comes out of depression, but you don't hear psychosis.
Yeah.
That word is just always left out, always. So it can help families in some ways, but without being a little more education on it, it can only help them so much.
I think it's buying in and perpetuating the stigma by not using
Yeah,
the word psychosis. I
Yeah.
stay away from schizophrenia, but I think psychosis sounds a little more acceptable in some ways. Although, you know.
Yeah.
But we need to start using it. It needs to become just another term in our language, you know, not something to
With
be.
use, the fear or whatever goes away.
Yeah,
but
yeah, exactly.
that's right.
Normalize
Yeah.
it, normalize
Yes.
it.
Becomes normalized, yeah.
Yeah.
In junior high and high school for when they leave high school and.
Yeah.
and
Now, there's
yeah.
curriculum in the schools now, with respect to that. They're actually bringing it down from high school to junior high and a little bit in elementary as well with respect to mental health.
That's Stan Kuchar's.
And Stan's
program,
working
yeah.
there as well. So, so, yes, a lot better in the last 5-10 years. And the main thing is to make sure that we don't sort of rest on that.
Yeah.
And that we have to make sure, it can be a little bit better, a little bit more, and it has to be continued. Like I say, that whole generational change, it just takes that 30, breast cancer, testicular cancer, the same thing. It takes 30, 40 years of that constant information processing to get out there.
But with what's happened over the last few years with the Mental Health Commission of Canada and some of those other things, I think, that there's greater acceptance greater chance of receiving a message now than even 5 or 10 years ago.
Yeah.
Certainly 10 years ago.
Yeah.
But, so, we do, thinking of the society, have to strike while the opportunity is there. And in a multifaceted way, the schools, general public, and many areas.
Maybe sometime soon the word psychosis will come out. We start for 5 years on mental health, but it is a specific area that word is left out.
Any questions or comments from our guests?
But I mean, you're the group, you're the best advocates for this as well. Because oftentimes we go to government or something as clinicians, the work that we do sometimes comes across. We push for this. I think it's more self-serving. But when honestly, across the country and worldwide, when things happen, it's because of advocacy on family and patient groups.
Do you know if the government, Department of Health and Wellness is looking at an anti-stigma campaign or anything? I've never spoken to Patricia about it, but.
I don't think so. I mean, there's some things ramping up federally, but I'm not sure about provincially. That's a good question, actually. To be honest, I don't know. There may be, and we just don't know.
We'll have to find out, or get something going, and maybe do a concerted effort, with the whole mental health community.
I think that's good. Yeah. Especially at that early stage. We have our interest in psychosis, but I mean, I think it would have more impact if we were able to have a more broader sort of knowledge base of getting that out there, the information. I will just move on. Just the other points here with this what they did in Norway. Just mentioned about they're able to decrease DUP, and then second, with the reduced DUP, symptoms at the start of the illness were less severe. So actually, with this whole campaign, when somebody actually came in for treatment, they found overall they were less ill than what they were before, or compared to that catchment area. Noticeable with negative symptoms, and particularly important was that reduced suicidality as well. And then they did a long-term follow-up up to 10 years, and they showed that improved functional recovery was sustained. All right, so and those with that shorter DUP were functionally better. All right, so it's an important piece. We talked about this a whole other. We can sit here and talk forever on this. What factors contribute to treatment delay? Right, insufficient information about psychosis and its stages, information about where to get help, that fear of mental illness and the associated stigma. The other kind of interesting point, and that's the second sort of major bullet point there, is that sometimes people who develop psychosis can have those multiple contacts with healthcare professionals. And oftentimes you have those multiple contacts before it's really get recognized what this is. Right? And even in Canada, I know Ashok, Dr. Malla, worked with a lot in McGill. They did a study when he was in London, Ontario, showing that when somebody, they actually wanted the indicator in their center where the treatment delay was if somebody actually was in treatment, right? Not necessarily in the first episode program, but if they were identified within the family physician or within community mental health, that actually delayed sometimes the referral into the specialist program. Something to think about. Okay. I put this up here. This is a study that we did, looking at pathways to care with psychosis. Because that was something when I moved here, I was interested to know what are the pathways to care when people come into our program. But this is one table that kind of came out of that. We did follow up with a rural population as well. Sample size, the numbers weren't too high, so you know, always I take that with a grain of salt. But if we look at barriers to help seeking, again, this is the first episode group. Okay, so what we did is we interviewed with kind of more some of the formal rating scales to patients who were in the first episode program or being treated for first episode psychosis. As you can see, the number, so barriers to help seeking, the first one, number 6 there, patients do not understand seriousness of problems, all right? And then the second one is number 7, that family or others did not understand seriousness of problems. Then there was a split between the rural and urban. And for the rural, it would be number 8. Patients did not know where to go for help, right? So that was a barrier. They just did not know where to go. Not only they didn't have the information, they didn't know where to go once they had it, which is different from the rural, where there's this inability to get to a treatment site, right? And I was interested talking to people. Yeah, it says, well, it'll take me an hour to get into rural, you know, and that was a barrier for them to get to seeking help. Right? So these are things that we need to consider. I mean, the other ones, as you can see, are high there as well. That patient too embarrassed to tell others to seek help. That's a stigma piece of it as well. Right? Interestingly, that wasn't number 1 though. It was more about the knowledge base. Okay. And so this is our own local data here. So the 4th piece, we're just moving on. Any other questions or comments about that? No? And so Donna, you can talk about this one. So family education engagement are an essential component of optimal treatment. True or false? Good answer. I wouldn't expect any other answer here. So, no, obviously an important point. And actually, I pointed to Donna because she did all this work in this particular key finding. And this is great because you were able to look at that literature and find, you know, all these different types of studies. We're able to just distill them down, right? And really seeing that family intervention can decrease the frequency of relapse. Family intervention can reduce hospital admissions. You found economic studies that showed that, you know, working with the families had a cost benefit to the individuals and as well as societal cost benefit to the system as well. Family intervention as well could increase adherence to medication. Right? Then we already made reference to why it's important for families to have knowledge and
to understand the illness. Yeah.
Understand, and that's a key component of our program as well, because, you know, we have to work together in that way, right? We know, I always say to the families, if you know the information, it makes our job a little bit easier and outcomes are going to be better if your family knows the information. And when I talk to an individual who says, no, I don't want my family involved, well, I say, well, but this is why we want to get your family involved. Because we know if your family's involved, or at least has the information, right? You may not talk to them, fine, that's your, you know, that's what you want, that's what you want. But if they have the information, it still will benefit you, right? They'll know how to talk.
And then unfortunately, probably some of us here heard the article in CBC this morning, a local woman whose brother was experiencing mental health issues, contacted the medical community on several occasions here in Halifax, could not get them to react. I wake up with the radio, and this was on when I was sort of in a semi-conscious state, and so I didn't hear the entire article.
I didn't hear that.
But it was, the information morning had been talking about the mobile crisis unit.
Okay,
They called it mobile crisis unit. They came, they talked to him, they left him, said he was not at risk, they couldn't do anything, and so on. I didn't catch what he did or what happened, but it was serious enough that she called in after hearing that program and anonymously ran through the whole scenario that was her experience, and it was like it was 7 years ago with the families being shut out and nobody listening, not getting information, but not being able to give information either.
Sounds like
Very
they
disappointing.
need some information sharing guidelines.
Yeah.
Review, that really shouldn't be happening today.
No, obviously
You know,
not.
I'm surprised, well, I'm not shocked, a little surprised, because I think most providers today, are pretty up on sharing information and at least listening.
No.
The problem I'm hearing though is, when your family member has psychosis or whatever, and you want them to get help, and they may go to emergency, right? But they're not sick enough to be admitted. They're psychotic and they're doing strange things, but and it's like we're always reacting, and it plays havoc, of course, with the treatment. That goes to the treatment delay. Too. The longer, bring them home. Okay, how bad do they have to be to get them in?
Pretty
Now,
bad.
Pretty bad. But having said that, I have been talking to, it was a gal over on Mayflower, and they do get a fair amount now of patients coming in involuntary under that third criteria for the IPTA. It's not, they're not a danger to themselves, they're not a danger to others, but there is mental deterioration. And she's seeing that they are admitting more patients with that. But I was really quite pleased to hear that, but I think we need more of that. We have to stop working in crisis mode and waiting until they are so sick that it's going to take so much longer to get them well.
Yeah. Oh no, I agree.
Sure.
Yeah.
And I think it's difficult because it's also frustrating for medicine as well.
Oh,
And
absolutely.
because you're right. I mean, when I'm on call, I see somebody emerge, like, no, you really need to be in the hospital. And I'm not going to say it like that, but then you try and you're spending a fair bit of time. So say, convincing somebody why they should come into hospital. But if they don't, because remember that Involuntary Treatment Act, that's a legal document. And you have to make those legal criteria. If you don't meet those legal criteria, that doesn't mean you're not ill, that you're just not making that criteria, right? And so that's a difficult spot. Because a lot of people, that would need some help. They'd probably be better off in hospital. I mean, the whole idea I always kind of come back to this too, and I was bring this around, is that, wouldn't it be great if it didn't get so bad that first point of contact was the emerge anyways? So this is all the other stuff that we've already been talking about, is that, if we still had that information out there, people were aware and things like that, I still think they'll probably still have that percentage of people where first contact is emerge, but if we can minimize that to the best that we can, I mean, I think that's what we should be aiming for, right? Because that's a horrible experience.
First point of contact should be the family doctor.
Yeah. But it should be outpatient care. It shouldn't be an ER and under potentially a coercive type of environment.
Yeah, and we're still out in, they do have the area for mental illness within the
ER, the pods
in the ER. Can't think of the term now, but you're still waiting outside in the main area with everyone else, and then that can be really, discouraging and embarrassing and whatever.
Well, it says we got work to do.
Yeah.
We still have work to do.
And yet, there's been a big improvement too. I mean,
There has
forget
been a big, huge.
I know there has been.
yeah, absolutely.
And I think that's great, and we always should celebrate these successes as well, right? because sometimes we don't celebrate the changes and the successes that we have.
Yeah.
You know, we can get ourselves worn down with the system still in its current state.
No, we've come a long way. I think
That's
when
just
the
like
chapter
relapse
started
of
7 years
criticism.
ago.
Ask me in 2 years if you've come a long way.
Yeah.
Really?
Yeah.
I'll put this and Donna, these are Donna's slides actually.
Yes, and I want to change those.
Okay, so you won't
As a
talk
matter of
about.
fact, I did send them in to be changed. You just didn't
So-
change your stick.
I don't think
That's
so.
all.
So I'm not gonna comment, you know, because obviously
Yeah,
the work with families, we need the families involved, period. There, okay. And we talk about the barriers to family engagement. We talk about those confidentiality issues, but as well we have to have those psychoeducation groups, and it has to be available as well, right?
and we do have I don't know if it's on the next slide.
No, I think that's the last one.
Okay, the family, I do want to mention, especially for anyone that's within the province, because we do have the Family Matters groups being offered throughout the province. That's an 11-week education program that is highly recommended to attend. You know, we do have them, so seek them out at if your clinic, if the local clinic is not offering them now, find out why, because they, you know, there is training for facilitators and they should be able to get something up and running. If they're not offering it now, they would be able to do it within a few months.
Call the schizophrenia office and tell them.
Call the Schizophrenia Society, sure.
Society office,
Yes,
yes.
And we'll find out where the nearest
Yeah.
program is.
The other thing within our CDHA too, we talked about information sharing. You mentioned it. I mean, there has been developed the information sharing guidelines. There actually is consent for, and that's sitting at sort of that quality council level, because there's actually a little sheet that needs to go develop to help clinicians with that. You know, really what it is. So I mean, that's really going to help with that interaction between clinicians and family members as well.
Well, I think the important thing to remember with the information sharing guidelines, especially for the person with the lived experience, that they need to be aware that their information is still confidential. I mean, there are only certain things that, you know, that if they want to share, that will be shared. And really, families are only interested in, you know, what's the treatment? You know, what's the best treatment, or what's the best thing I can do, or what shouldn't I be doing?
Yeah.
You know, we really are not interested in knowing what you're discussing in your therapeutic session. We want to know what the treatment options are.
You know, there are some parents
And
who
how-
want to know exactly what's being discussed. In
Oh gosh. Okay, all right.
So there's no difficult parents, just difficult
Parents
sometimes.
with families with difficulties. Yeah.
So, but also, I mean, you know, we instill that. I mean, that's just an ingrained culture within our program as well. Is that, you know, we could have somebody who comes in initially doesn't want family involved. Eventually, usually families involved. You know, or at least, you know, we have that ability to at least be able to talk, and not always at some, but you know, even when it's not been an issue, say, look, you know, your dad's out there, your dad's or mom's calling, you know, I'm going to talk to them, you know, I'm not going to tell them everything, but, you know, just to give them some information. You know, usually people are fine with that.
Yeah, I think most people, individuals, do want their families involved. I mean, they would want them involved if they had cancer, or if they, you know, were very physically ill.
Yeah.
They would expect support from their family. So that should, and I must say there are some in the profession, you know, providers that actually discourage, you know, individuals from, oh, well, you're old enough, you don't need your parents, you know, so that's still a little bit of a problem, but that we're working on.
We always need our mothers.
Yes, we do, of course.
Fifth point, just so here's moving on. So this is actually an interesting point that we brought up again within our conference of the regions and the province here. And this whole idea and concept about mental health psychosis particularly, it's not necessarily a progressive brain disease. And that's sort of the take-home message there. And there's a lot of work that's gone into it. It's mainly in my area with respect to neuroimaging. And really what it says that there can be those changes in in neuroimaging parameters, so like tissue volumes and things like that, different parts of the brain with psychosis. Generally, what we're seeing is that even when somebody presents at that first episode period, we're seeing those changes, right? So we don't know necessarily how much before that those changes started to occur, but oftentimes we're seeing those changes at first episode presentation, a decrease in volume, brain volumes and that. What we're not necessarily seeing is that progressing over time. Now, I think historically there's been that sort of a messaging that it's a progressive illness and continuous deterioration over time. And there may have been elements of that in the past, but even with now with our treatments, we're just not seeing that. Okay. That said, there is probably a small population, a subpopulation, where there is a bit of a deterioration over time, with controlling for all the other variables, but it's a smaller population. And in fact, there's more work that's come out of Iowa with Nancy Andreassen's group that have really looked at what's really driving some of those changes longitudinally is relapse. So those individuals with more relapses are having more deterioration over time with progressive brain changes. Okay, so that's kind of a messaging there. But the main thing to get to is that the majority of the group, yes, there are some changes that occur. It is an illness with some brain changes there, but it's not progressive, it's not deteriorating over time. Okay. And the last bullet point, that's been a subject of debate for a long time. And it's an active area of research now. Okay. So you know, I may come back in 5 years and say something completely different, but right now this is really what it's showing. Okay. Because I put this up there, that some of the changes in some of the older studies, what they haven't really controlled for are some of these other things that may still affect brain changes, right? Antipsychotic medications themselves, not necessarily the newer medications, but some of the older ones, actually has been shown to have some effects just on brain volumes, right? In some medications actually increase brain volume, and other medications decrease them as well, right? So you know, when any newer medication comes up now, really has to, you know, it goes through significant trials and really have to show that it doesn't cause any of this, all right? Cannabis use in itself can cause some progressive changes. You know, the whole cigarette, alcohol, other substance use, sedentary lifestyle.
How much difference does that make, this sedentary lifestyle?
Well, that's a good point. There's early work done on it. There's not, because that's a different one to control for without controlling for some of the other things as well, right? I can't give you a percentage of how much that would play a role, but we know that it does play a small role. It can play a small role in some of those changes.
And if you work on the lifestyle?
That could change, yeah.
Too late, or?
No. The brain is still a fairly plastic thing. I say plastic, maybe it can change. Even when you're 50s and 60s, you can teach an old dog new tricks, right? And there is some truth to that. So, so I mean, yeah. Now, is there as significant changes if you've had the illness for 30 years compared to somebody who's had it for 5? Yeah, it's not going to be the same degree of change, but some change can still occur. Okay. Yeah, basically what I'm saying, the last bullet point, that recent reviews suggest that brain changes directly related to psychosis do not progress after first episode. So so what does that mean? What do you take from that? And this is really what we discuss, is that in the past where we've thought of it as that progressive disorder, right? It's kind of fostered that pessimistic attitude about recovery, especially about young people, right? Young people are smart, right? There's a lot of, look at the average age of onset, right? I mean, a lot of our clinic people are in post-grad studies or post-grad, that being secondary, college or university, right? You get a diagnosis, and say you diagnose psychosis or schizophrenia. Well, the first thing that they look up is all the negative things about it, right? So it can,
well, there's not too much
well,
great about it
either, but what happens is that then they identify with the worst possible scenario.
Yeah,
and that's human nature as well, no matter what illness you're going to get, right? It's going to be that worst possible scenario. I started losing my hair. Worst possible scenario. So I'm going to be like my granddad. Yeah. I am. So, but you have to think about what cognitively and psychologically what that creates for an individual. Yeah. Right. So if you're able to say it's not necessarily progressive, then yes, no, this is not the same disease. You know, how we treat it and the outcomes are different than what it was 15, 20 years ago, right? And that's a lot of the messaging that needs to go into that. So that's, you know, they support that attitude that recovery in some form is a realistic goal. I mean, I don't want to get the whole discussion of what recovery is, but yes, we can talk about recovery, right? And it is a realistic goal.
That's almost a form of education too for the clients.
Oh yes,
And
yeah.
again, I will say this should also be in hospital.
Mm-hmm.
This a form of a kind of education for all clients.
Right. Yeah. Yes, I mentioned that we're looking at our delivery of services for psychosis for the region. The inpatients are kind of doing a very similar thing as well, sort of looking at their services. So I hear you, and other people have heard that too. So
Is there any, right now, I guess, is there any formal education module that they do with patients when they're
an inpatient?
An inpatient?
I'm going to say no, but don't hold me to that. Because you have to appreciate, I think it would be very difficult to actually do. It's more on a one-to-one basis, right? Because you can't just say, okay, this is going to be our every 3 days for 2 weeks because people are in and out all the time. So actually from a truly process point of view, it'd be very difficult to implement, right? But more on that one-to-one, that could happen.
They have to be at a stage ready to hear it.
And true, they have to be safe. And a lot of times, well, you know, what's the purpose of the inpatient? Sometimes it's to set the stage for the work that's going to happen on the outpatient basis.
It's really just to stabilize.
Right, so you stabilize it, but you may be bringing in these concepts and ideas, but as well, really, a lot of that should be happening on the outpatient basis, right? So yes, you can talk about recovery, you can talk about other elements of all this too, and you bring that into, you know, how are you going to stay at hospital, right? I mean, going over from psychosis point of view, going over your, you know, like say, relapse signature. So what kind of, you know, that definitely should be that focus of that inpatient. But that also should be carried, a meat of that should be carried into the outpatient treatment. So this is just the, you know, kind of take-home points about supporting recovery. I think everybody here appreciates this. So that everyone working with people experiencing psychosis can positively influence outcomes by engendering and supporting that realistic, positive attitude. And, you know, really it's embracing a recovery-oriented perspective. Right? And that's how we talk with our youth and young adults, right? And again, it's maybe phase specific, but, you know, letting them know, yes, you can get back to university, you can get back to your college and your degree program, right? And there may be struggles, but I mean, if that's your goal, then we'll work towards that. There are some people who won't be able to, okay, right? But that, you know, then there are other goals, right? There's other recovery things that you strive for. So I think that's the last of my slides. I think that the last one is just, that's just our group.
I just don't even remember having that one, James.
That was in the Annapolis Valley.
Oh, okay.
So that's where we presented this whole key finding initiatives to the Annapolis Valley group as well. In there, so I can't remember who she is in the middle. So she's one of the administrators.
Oh, the administrators down in the valley.
One of the
There's one question.
Yeah.
It's from John Roswell's. It says, according to my understanding, it is generally agreed that psychosis involves a break with the reality most people experience most of the time. Is there any school of thought that considers the possibility that psychosis is actually a state of heightened awareness? Perhaps the reality is beyond that which normals usually experience.
Yeah, no, it's a good question. There's different ways of looking at it. Because for me personally, I always have a bit of difficulty thinking about what is a break from reality. Because perhaps I try and define, well, what is reality? You know, it's sort of a higher level sort of concept and idea. The one thing that I'll point with respect to that, which is relevant to that, is actually some of the biological things. I have sort of kind of go back to that with respect with me. And from a neuroimaging perspective, there's abnormalities that can exist within the thalamus part of the brain that's sort of responsible for filtering information. So we talk about, you know, for example, right now, there's a lot of things that are going on. There's noises outdoors, my chair is creaking, the sound from there, there's other little sounds in the room. We're able to filter that, right? so that we can have salience and that we know what's important and what we need to be paying attention to, and those other things are diminished, right? You just have to think about it. If we don't have that, you would be bombarded by all these sounds, experiences, things that are going on, either visually or auditory as well, right? And if that's occurring, yeah, that would be considered a heightened reality, right? If you think about it. But what it is just you're more sensitive to all these environmental things that are going on. And that can happen with, and that does happen with psychosis too. The kind of the concept of those auditory hallucinations, I mean, really what are those, right? I mean, we're human, we have internal thought, we talk to ourselves, we make our mental lists, we do all that, but we appreciate and understand that that's our own thought, we created that. Now, if we didn't have that filter to really appreciate that, then it would be an external voice, right? That we didn't have control over that. So there's elements, I appreciate that you're saying, but yeah, so the biologically, that is what's happening. That is sort of a heightened sense of environmental stimuli. Some of our prodromal symptoms that we've had with some of the guys, I remember one guy specifically when I was at West, big hockey guy, and played very high level, said he knew something was wrong because you go into the hockey rink and just the lights were had a different feeling to them. They were either stronger, they vibrated, there's just more going on. He just knew that something was wrong.
Is that like perceptual?
Yeah, that is perceptual.
Perceptual hallucinations?
Yeah,
Not...
well, yeah, along those lines. Yeah, yeah. So they, appreciate, and sometimes if there was, you can appreciate that something's wrong, right? So yeah, so that is definitely a thought, but there's also that biological sort of underpinnings, which we can try and explain that as well. So, I mean, just appreciate your own voice, like that mental list that you're making, things that you're thinking about, right? All of the swearing that you were doing when you forgot the chords and stuff, and you if you didn't appreciate that was your own voice, well, how do you think what would your reaction to that?
That's just me going off as usual.
Internally, not externally.
Yeah.
So is there
One more question.
Oh, yeah, sure.
A question from Ben. How has research shown early intervention to function across family, individual income, education, geography, etc.? What impact do these and other factors have on dropout rates from programs like EPP and expected outcomes of early intervention?
Okay, I'm just trying to get the message with that question. So,
other factors like family and individual income, education levels,
I see.
geographic areas, rural versus urban perhaps.
Yeah.
What impact do those have on dropout rates from programs like EPP and expected outcomes of early intervention?
Yeah, actually, no, that's a really, really good question. We know that geographically, there's some studies, because a lot of the UK studies have looked at geography, especially within, for example, within the city of London and all the different boroughs and New York and things like that as well. That doesn't necessarily have an indication in dropout rates. In fact, oftentimes there's a lot of case finding with respect to that because of the urbanicity and the findings there. Not a lot of work has gone into sort of socioeconomic status. I'm looking at you because you asked the question. I feel like you asked the question, so I'm answering you. Not a lot of work has really gone into that whole idea of socioeconomic status or ethnicity as well, and how that relates to people coming in as well as staying within the programs as well. It's a good question. I don't have the answer to that, to be honest. So I know one thing that that's been eating at me for a little while as well, and I've started looking into it is the African Nova Scotian population as well. Until somebody pointed out that most of my patients were of color, I thought we didn't have a good representation within our clinic. And where are these people? How are they being served? Obviously, community has a different, various communities play different roles within that too. So I'm still looking into that particular angle of things.
They had a great conference last week or 2 weeks ago.
Yeah. Okay. Good. I've had conversations, with various community leaders on that. So yeah. All right.
Okay. Is that it? Any other questions? Well, thank you so much.
Pleasure. Well, let's apply them to the Sorry.
Dr. Tibbo, that was a great presentation. And next month we have the second, I don't know what the date is, the second Monday in January, and we have I believe Golden Matthews is going to be speaking on stages of change. So tune in then. Thank you for joining us, and thank you.
No, my pleasure.
Yes.
Thank you for people joining and staying on the webcast.
Good night.
Thank you all for bringing in your
Okay.
laptop.
Donna, you did make the statement that when Phil was saying about the young people being, very, not inquisitive, but doing the research and coming up with all the negative things about the disease. He said, well, there's not much positive. My son would argue with that. A couple of years after he was in it, and
Yeah.
we were talking, he says, well, at least I don't have to worry about identity theft.